Welcome everyone to Healthcare for All, brought to you by WCANradio.com. This program examines the issues of healthcare for you. Join us now in the studio where the program is in progress.
Good evening. Welcome to Healthcare for All, sponsored by SPAN Ohio. I'm Debbie Silverstein, your host, and I'm in the WCAN studio with my co-host, Eric Meadows, and our guest tonight, Dr. Betty Keller from Vermont. Good evening, Eric.
Good evening, everyone. I'd like to welcome you all to Healthcare for All. It's a great show. We're going into our 14th month, and it's absolutely amazing what the show has, has
And if I can interject something, too, with this, I just want to let our listeners know, during this program, feel free to go to the Healthcare for All page on WCNradio.com. We have a little comment box underneath, and you can put your comments during the program while you're listening to the show. Thank you. Back to you guys.
Thanks, Tim. Thanks. Yeah, it's 14 months, Eric. It doesn't seem possible. I mean, we just started this, didn't we?
Yes, we did. Yes, we did. And I really have to, give an applause to all of our listeners simply because they have performed so well, not just with the listening, but, with becoming participants in making this show so possible. Tonight you said our guest is Betty Keller, Dr. Betty Keller. I want to welcome you to tonight's show. How are you?
I'm doing well. Thank you so much for inviting me.
Well, Dr. Keller is a physician. She's a Vermont activist. She's a mom. And she's been very involved in the single-payer movement in Vermont and in helping Vermont achieve a bill that will lead them to a single-payer healthcare system. Is that correct, Betty?
Pretty much. I mean, there have been many, many people involved in this. I didn't have any kind of a central role in any way whatsoever. But I'm one of the many advocates who have been working hard on this to move our healthcare system forward.
So will Vermont be the first state to get single-payer?
I'm not sure. I know that there are some other states that are working hard along the way, and a lot of it has to do with the federal government and whether they pass legislation that allows for waivers for certain things. For instance, there's a state that would not have to get a waiver for ERISA because they were grandfathered in. So if we have some stumbling over that at all, then they might get there first. In an ideal world, we wouldn't get there first because the whole country would get there at once because we would pass a national bill for single payer for the entire country.
Well, that would be really great if we could do that. But a lot of people believe that it's going to have to happen in the states first, just like a lot of other social changes did. The women's right to vote, equal rights, civil rights bill, and a lot of other things like that. So we're looking at the states, and I guess a lot of us are hoping that Vermont will be first, or that one state will be first, and that some other states will follow. So if there's two of you that are really close, that's even better.
Yes, I think that there is a lot of value to having states be sort of incubators. On the other hand, healthcare laws are so complex. For instance, if the federal government requires that you all have an exchange, then you have to get special permission to do something different because single payer, by definition, wouldn't have an exchange with multiple insurances in it. And when the federal government has laws about what benefits employers can provide and whether the states can or can't tell states that they can't provide health insurance because the state is doing it, and other means of providing health insurance would make it harder to have the bulk number of people that are required to run it effectively and efficiently. Mm-hmm. So having it, just like Medicare did not go state by state, mm-hmm. we just did it across the country.
Correct.
It would be easier administratively and for just having it be consistent mm-hmm. to not have to worry about the borders of, is everybody going to flood into Vermont and make it unaffordable for us to take care of everybody's health if we don't have the neighbors having health care also.
Well, I'll tell you what, Betty, I'm planning to flood into Vermont. I'd love to.
Dr. Keller, I do have a question. If you can just explain to our listeners, you say in exchange and single payer that the insurance companies, there would be multiple insurance companies, but wouldn't they be governed by one rule?
The exchange is required by the federal Patient Protection and Affordability Care Act, the PPACA, mm-hmm. and the exchange requires a variety of plans within that for employers of the smaller businesses and for individuals to choose from. And that, by definition, isn't a single payer. And you cannot get the administrative costs lowered by that. They actually increase the administrative costs. But to have some consistencies across the board, like having a single benefit plan that they all have to meet at least that, and developing a single system for reimbursement for the providers. In some states, they might set a single actual payment, so all providers get paid the same amount. That's what Vermont is aiming for. For one provider to do a particular service, then every of the same kind of provider providing that exact service would get the same payment to make it more administratively simple. And so your question was about the exchange. Can you bring us back to what your question was exactly?
Okay, with the exchange, wouldn't it be multiple insurance companies? They would all have to adhere to one set of principles, one set of plans to administer health care.
Well, they still have to offer both a bronze and they have to have at least 2 plans on the exchange. And I can't remember what the exact rules are because, frankly, I don't actually have to deal with that. I'm not, a paid administrator trying to develop an exchange, and I'm really working for single payer, and you can only put your attention on so many things at once.
Right.
But the exchange is rather more complex, and yes, they do have to meet some criteria, but beyond that, you can do a better job, for instance. So although it's far less complex than what is currently happening with literally hundreds of plans out there, it still is way more complex and is financially logical.
Well, Betty, Vermont has passed a law that you believe is going to lead the state to single payer, correct?
Correct.
And what exactly does that law do that will lead you to single payer?
So in 2011, and this was not out of the blue, this was something worked on for a couple of decades, okay? Worked on really hard over the last, depends on how far you want to count being really hard, but certainly for the last 10 years it's been a major focus for a number of people, including legislators, some of whom ran specifically because they wanted to work toward getting a better health care system. And so having had so much activity going on for so long, in 2010, we had a bill that required hiring a consultant to design 3 systems. And one was going to do the analysis for what would our cost be if we did everything in the PPACA, so you could know what you're comparing to. People say, well, maybe we'd be fine under that system, So if you compared to that, and then did one using single payer, and then another plan of the designer's choice. You're comparing 3 plans in case the designer came up with some other different plan that might be better, and then report that in January of 2011. And then the legislature was supposed to make the best choice of that. And so when 2011 came, and the report was not surprising because we've had similar reports saying that, yes, single payer would save a whole lot of administrative money so that you could then use those savings to cover the people that previously weren't insured. And so that law became Act 48.
Okay.
And one thing it did was spell right out that health care is a public good, and Vermont will develop an integrated health care system to provide health care to all of our residents without linking it to employment and making it accessible regardless of income, with a single system that would be responsible for administering all the claims for all the residents and all the payments to all the providers.
Okay.
So that was one thing it just did. It just said, we have to do this as public good, and we are going to administer this. And so another thing that it did was it set up the Green Mountain Care Board, which is not elected officials. They're appointed by the governor with input from the legislature, okay?
Okay.
And so there are 5 people on this, and their terms are different, so they leave at different times. And so there's some continuity. You don't have all fresh people coming on all at once. And their job on the board is to control the rate of growth of health care costs. The Patient Protection and Affordability Care Act did not provide patient protection. It provided more than what we had before, but still not really patient protection. And it doesn't in any way make care more affordable. It makes them more affordable in that we're giving them premiums, but it doesn't bring down healthcare costs overall. It just means, we'll pay more taxes to pay those premiums, to help pay those premiums. But it doesn't actually bring down or even bend the curve for.
Yeah, we had, Eric and I had a long discussion about that before the show, And his question to me kept saying, well, where's the affordable care? Where's the affordable
Yes.
care?
All the affordable
Yes, it's just
care
in
has,
name.
all that happens is that you have premium subsidized.
Right.
So it's more affordable for the lowest income. But that's all that's affordable about it. And it's not as good as it's not as affordable to Vermonters as what we have currently been doing through state subsidies.
Right.
So the lowest income people are going to have their rates go up with exchange unless we put in more subsidies beyond the exchange.
Well, what is affordable, what they're making more affordable is insurance. And you haven't even gotten to the care yet.
Exactly.
So
the Green Mountain Care Board is supposed to control the rate of growth of healthcare costs,
Of healthcare cost, okay.
reform the provider reimbursements.
Uh-huh.
And that one of those things by reforming the provider reimbursements is to try to figure out ways to provide financial incentive for people to get help to stay well or to get well faster and then stay well. Because right now, really, your doctor gets paid more if you get sick and if you keep on having to come back.
mm-hmm.
And doesn't have a lot of motivation financially to try to get you well without you coming into the office, because they don't get paid unless you come in. So you have to miss work to come in and get seen.
Mm-hmm.
And so there are many things that right now work against the patient.
Well, yeah,
So
if I could ask,
on that?
can I ask a question about that? I'm kind of confused sometimes about getting well quicker and staying well. I mean, it sounds like it's a choice on somebody's part. You know, as a patient, I want to get well as quick as I possibly can. I don't have, you know, the patience to be sick and that type of thing. And so, I mean, how do I get well quicker?
Well, if you have providers trained better to know how to really move things along faster, no more choices, rather than only relying on drugs that may not be all that effective.
Okay.
And if your insurance doesn't pay for nutritional counseling and your doctor doesn't have time to give it, even though you may want it, you may not have money for a nutritional consult.
Uh-huh.
So even though you want to get better, you want to figure out how to eat better, you want to control your weight better, maybe you would like to exercise more, but you're worried because you have a relative who died of a heart attack and you don't have money for a cardiac stress test, you don't have money to join the gym, those sorts of things. So if we can figure out how to reduce those barriers
Mm-hmm.
for people trying to take better care of themselves.
Okay. No, I've got another question along those lines. You know, there's a lot of talk about paying doctors for keeping people well and basing the pay on that, on the quality of their results rather than the visits and so forth and that type of thing. You're familiar with that, right?
Right, the medical home model.
Yeah. Now, I have a question. Can a doctor be penalized for doing their job the best they can, but the patient doesn't do what they're supposed to do, and that you don't get the results that you want, and the doctor's being paid on the results, but the patient goes home and smokes and drinks and eats a lot of junk food?
Right. Right now, the way Vermont is managing the medical home so far is that you have a panel of patients and you get paid per head. And right now, we don't dock you for your patients not losing weight on a particular schedule or whatever like that. So right now, it's just that you're just getting paid per number of people on your panel.
Okay.
Now, on your panel, say you work in a clinic where there are several doctors, several nurse practitioners, a nutritional consult, a behavioral health specialist, and a social worker.
Mm-hmm.
And so when you see that diabetic, you refer them to see the nutritionist, and if there are issues around stress and not being able to go and pick up healthy foods because they can't do their own shopping and the relative who shops for them isn't paying good attention and doesn't know or doesn't follow the instructions for what they're supposed to eat, okay? So instead of the doctor spending time in the office chastising the patient or instructing them on how to do better, even though the patient doesn't have a lot of control over all of it, the doctor has the social worker talk through with the patient what's getting in the way,
Mm-hmm.
and then calls in the family member to come to have a meeting with them about what kinds of groceries you need to buy.
Mm-hmm.
Okay? So right now we're not collecting data on saying, well, over this much time, these patients weighed this and this was what they were supposed to weigh or something.
Okay.
But, I mean, that might potentially be looked at. If you see that somebody has amazing results and there's less obesity in the Northeast Kingdom because now all of our clinics are doing such a much better job of calling people in and getting them into clubs or whatever it is, then you might look at that, or you might just, pat yourself on the back and say, hey, we're doing a great job for our community. Don't we feel good about that?
Mm-hmm. Well, and I suppose, I guess the way you explained it, that makes some sense to me, because the more successful the doctor is with the patient, or the more successful the patient is, then the less service they need. And the doctor's getting paid the same amount whether they come to see them once a year or 20 times a year.
Right. Right now they get paid per head just for the management, but they also get paid for when they come in and take up more time in the office, or when they get, go to the hospital or something. Mm-hmm. In a managed care organization, it's different, but we aren't doing that yet. But that's part of it. This innovation that's being, there are grants through the PPACA for states to try to innovate and figure out ways to do things better. Okay. But you have to look at aggregate numbers. I mean, if you have a doctor who's known in the area as the person who will really listen to you when your case is complicated and nobody else has patients to try to figure out what's going on, and that doctor gets all the most complicated patients, they're not all going to have the best outcomes because they've got the worst, most challenging cases. Mm-hmm. So you won't want to dock that doctor for doing the best he or she can with a challenging caseload. But you really want that doctor to have to enjoy their job, to feel some reward in the job, so they'll stay there. Also, you'll have an underserved community if doctors won't stay. Mm-hmm. So that's actually the next thing I was going to talk about after reforming provider reimbursement, was developing the workforce. Mm-hmm. When I was before I applied to medical school, there had been a system, a public health system, where if you were planning to serve in an underserved area, you could have your medical school paid for, or at least have some of it paid for. And right the year before I was applying myself, they got rid of that program.
Oh, no.
And, of course, then they started up again. Of course, exactly where I wanted to work was an underserved area. But anyway,
yeah.
So we finished paying off my school loans about the year that my son went into college, and we had his school loans.
Oh, my.
But anyway, so developing the workforce includes figuring out what you need where, and figuring out which kinds of providers. So, for instance, if you need more primary care, do you need it to be all doctors? Would it be more cost-effective to have nurse practitioners and physician assistants too? Is it possible to recruit enough doctors? Do you have to look at other providers? How about specialists? If you are in a very rural area and there's really not enough business to have, a large clinic with 3 orthopedic doctors and actually keep them busy enough, what do you do to keep 1 or 2 there if they can't be on call every day? Mm-hmm. You have to have the doctor not burn out. So those sorts of issues are important for the Green Mountain Care Board to sort through to make sure we have adequate primary care providers and specialists, and the adjunct people, the behavioral health specialists, the social workers, distributed adequately around the state, not all concentrated in the Montpelier and Burlington areas.
Okay, now, who determines exactly what's covered under this healthcare system and what isn't? Is that also the board?
Let me think here. The administration is in charge of planning what the benefits plan will be.
Okay.
So that's not actually the Green Mountain Care Board, I don't believe, right now.
Mm-hmm. Dr. Keller, I do have a question to ask. On the time limits for implementing these different areas of care, is there one that Green Mountain Care Board has started? I mean, do they expect to have all this in place in the next 10 years?
Well, we're actually hoping to have it all in place by 2017, because that's when the federal law allows us to apply for a waiver. And we actually plan to have things pretty much in line so that if the law were changed and we could apply by 2015, we would do so.
Okay, let me ask you one other question concerning the waivers. A lot of people have heard a lot of talk about it, but can you go in depth with that? What does it mean for the state to apply for a waiver?
So when there's a federal law, all the states have to comply with it. But if there's a reason that you think that your state can explain why you shouldn't have to comply with it, then you can ask for a waiver. So, for instance, if you say, well, we shouldn't have to comply with it because we don't have enough money and we just don't want to do it, well, that won't really pass. You won't get the waiver for that. But if you say, look, we have a more cost-effective way of doing it, we can cover more people and spend less money, that would be a pretty good excuse for getting a waiver. Mm-hmm. Okay. So you look at the federal bill and you see what are the things that you don't want to comply with, and then you write a request for a waiver for the things that you don't want to comply with, and you explain why you think you can justify it. And in the PPACA, actually, you're required to have public hearings before you apply for the waiver to make sure that your communities all agree that they actually want their legislature to look for a waiver rather than to just apply for it. For instance, if you lived in a state which had a lot of poverty, and you just said we can't afford this exchange, and you wrote a waiver just trying to get out of it, and people heard the hearing and heard, oh, well, then we just won't have insurance. And although right now the federal government is willing to subsidize our premiums, the state just doesn't want to do it, and we won't get those premiums the federal government has said we deserve. So when you have these public hearings, they'll say, no, don't apply for the waiver. And so that's one of the rules that's in the PPACA for compliance. If you're setting up a single-payer bill, you have to show that you have had your public hearings and that the public is agreeing and your legislators are passing a law affirming that they may apply for the waiver.
Well, now, that could be a timely process. So during that interim, what does the public have as far as health care coverage?
Well, right now, we have to have the exchange up and running. We have to have it ready for people to apply for by October of this coming year, 2013. And we have to have the exchange ready to have people in it. Have the actual reimbursements happen, the claims happening by January 1st of 2014. Now, not every state has to do that. You can choose to not set it up and let the federal government set it up, but it will be set up. If you don't do it, the federal government will do it.
Right.
And so in the meantime, before single payer, they'll have what's required by federal law, which is the exchange, and they will, if their employers provide insurance, then they're over 100 employees, over 50 employees, then they will do that. If they're under 50 employees, then the employer has to purchase through the exchange, or the employer can decide to not purchase insurance, which might be beneficial to the employees, to have the employer not provide it so that they can get these subsidies through the exchange. The other thing is that if your employer doesn't have to purchase your insurance, and if they have been only hiring 3/4-time employees because they didn't want to have to pay for insurance too, then you have people juggling multiple jobs trying to just pay their living expenses and still not having health insurance.
That's right.
If you take away that requirement of employers to have to provide health insurance for full-time employees, then they can hire people with less administration of juggling so many employees and have happier employees because they're not so stressed running around to different jobs, and they can have money that would have gone for premiums freed up to use for reinvesting in the company.
Okay, sounds
now,
like a plan.
So until you get the waivers, then you are under the federal bill, the Patient Protection and Affordable Care Act. When you get the waivers, then you move to a single-payer program, correct?
That would be the goal.
Okay. Now, the question is, Vermont is kind of leading the race in this, and the other state that I believe is close on your heels is Hawaii, correct?
They're the state that doesn't actually have to worry about ERISA. They had something going on already in their state and got a waiver on that.
Yeah. And is that Hawaii?
Yes.
Okay. So the two of you are kind of, leading the pack. Why did this happen in Vermont?
Well,
Was there something special about Vermont that made this possible, that it hasn't happened elsewhere?
I wish I could say there's one special thing that would make it all obvious, but there really are many, many features that went into why it could happen in Vermont. And there are other states that may have a few of those features, but not many actually have all of them. There are a lot of features that went into it. There's been a long history of advocacy for health care being a public good. Before people use the term single payer so freely around, we've been saying for a long time, we need to provide it as a public good. Just like we provide our schools, we build our roads and maintain them, provide our police protection, that there should be a public good like these other things.
Okay.
Another thing was that we'd had this long history, and we had actually made multiple little incremental steps, and we had seen that none of them actually changed the cost curve, that they improved access. But then as more people took advantage of the access that they now had and were getting the health care that they could, then it cost more, and you were providing this access through subsidies for private insurances typically, so it was very expensive. And when you had harder economic times, then those things got cut and less people would enroll, so you had a higher uninsured rate.
Right.
So then you were back to where you were with people showing up in the hospital. So instead of getting their care earlier and more cost effectively. So even though we'd done all these little steps, we had seen that it wasn't really fixing it. So many things that were in the PPACA, Vermont had already done. There's like 2 things that weren't. One of them was getting your children to be able to stay on your health care until 26.
Right.
And that was the main thing. I can't even remember what another thing was. That's like that was the big thing we all talked about. Oh, that helps for that little time.
Right.
But,
Well, I've heard it explained that when you do those little incremental steps, it's like pressing down on a balloon. When you press down on one area, another area pops up. So you just create a problem somewhere else.
Right, or like if you're sticking tape over something leaky and it just leaks out somewhere else. Well, the other thing is that if you do the incremental steps, then the people that you help are less likely to work as hard for it because they're a little bit relieved now. And so you have, less pressure from so many people to do it, but you have some people who are just really, really hurting. So you have to make it clear to more of the public how important it is, even if your problem has been taken care of, that we really need to take care of each other.
Right.
And the job isn't done if your next-door neighbor still can't get the care that he or she needs. Or when your kids get laid off and they can't get their care. So there was a lot of pent-up frustration about not getting anything really accomplished with these incremental steps. And in our particular setting here, Vermont tends to, when we elect a governor, if he or she is not screwing up, then we keep on re-electing them. And so we like to give them a chance to prove that their policies are or not going to work. It's only a 2-year term, and you don't want people just continuously running. You want them to actually get something done. So if they're not screwing up, give them a chance to, keep on working on their policies. So Governor Douglas was a Republican governor who was a very nice guy, but he was very much a roadblock on health care reform because he really was a firm believer in the private market system to be able to control costs, and which just cannot work. The principles for bringing the costs down don't work in health care. So, but he had trouble accepting that, and so he was pretty much of a barrier for getting an actual universal health care system in while he was here. So when he chose not to run again, finally in 2010, there was all this pent-up energy that, now we can finally get something done. And there were 5 Democratic candidates running in the primary. And of those 5, Governor Shumlin came out first saying that he supported a single-payer system. And as people heard the news of how well that was received, we had a lot of candidates, moving more and more towards supporting it, or at least saying that they were open to it. And it was an amazing year to see what was happening politically right then.
Well, now you mentioned that he said he favored a single-payer system. Did he use the term single-payer?
He used it pretty early.
Did he?
Yeah. Like, all the advocates were shocked. We're like looking at across tables at each other saying, well, should we continue avoiding it if he's not?
Yeah. Well,
so many people don't understand what single payer is. And if you don't understand what it is, and if you listen to a lot of the myths or the just whatever proponents who are opposed to the concept of having a universal health care system, when you say single payer, it makes it sound like, one monolithic system that we won't have any control over. It'll be forced down our throats. We won't have any choices. Those are the phrases that go people through mind because they've heard them on TV.
Right.
But in reality, this single-payer system is a public system, so it's publicly accountable. So it's one single system, so it's integrated. It's coordinated. You have some control. If you're not getting your claims paid, or if you're not getting your health care covered, you have somewhere to go. You can go to a board that's accountable to you. You're not like sending an appeals process in, and who knows how or why they decided to cover it and whether it's going to go anywhere when you go through the process of trying to appeal, The insurance companies are not transparent. They're not accountable.
Right.
your government is. You hire these people, and you can be on advisory council. You can go watch the political process. You can tell your own legislator what you want him or her to do. You have more say in the whole process.
And that depends on the state you're in. What we're seeing, we've seen some states where the legislators don't listen to the people. I mean, we just saw a scene up in Michigan where they had to have the police out guarding the state house from the people because they were enacting laws that the people did not want, and that type of thing. But that kind of I guess, culture didn't exist in Vermont for you.
I don't know what it's like in other states, but Vermont, your legislators. You see them in the grocery store. They come knocking on your door to get you to vote for them. You see them at town meeting. I mean, the legislature shuts down for the week of town meeting, which is in the first week of March. And town meeting is on the first Tuesday in March. But they come home the Friday before. They're there for the weekend talking to their constituents. They're at town meeting day and at one or more of the different towns, because they serve several towns. And then they talk to people, and they're there for the rest of the week to hear what people were concerned about. And then they go back to the legislature Tuesday through Friday again.
Are the town meetings well attended?
It's highly variable. Some towns still have town meeting during the daytime. Some towns do it on the Monday the night before, because so many people work during the day and businesses don't all let them off now. And town meetings worked better when you had a lot of farmers and homemakers and people who owned their own little shop that could just close up shop for the day. But that doesn't help, people who work for a hospital to get in, or other services that, are needed on a daily basis. So some have gone to Australian ballots for the people, but still do some of the other work at town meeting. But whether you live in a bigger town that has turned over toward Australian balloting or something, you still don't know your legislators. You still, if you want to track them down and tell them what you're concerned about, you can do that. So that's a very different thing. And your legislators, they're part-time. They only work from January through late April or early May. They only work 4 days a week. So they're home on the weekends and on Monday to see their constituents and their families and all. And the rest of the year, they have to support themselves some other way. And they don't get health insurance with their job for the state.
Dr. Keller, I have been wanting to ask this question because you've done such a wonderful job in explaining what single payer is all about. But how did you get the populace behind you, enough so to where the legislators actually did have to listen? It must have been enough people saying something about it in order to catch their ear.
We had several people who were going around to Rotary clubs and Lions clubs and things like that a lot, going to small businesses and coming and giving testimony at the State House. Deb Richter is one that people have often heard of. I think you've had her on your show before. So there was a lot of groundwork already done. But in that period, 2009 to 10, the Vermont Workers Center came to realize how important it was to so many of their workers. Even though you say, oh, well, they're union people, they have their benefits that way, they have health care already. But union workers were still worried about how much it was taking out of their salaries when they were going through these negotiations as the health insurance costs increased. They also worried about, well, when I get laid off, what will I have? When my kids grow up and they're no longer on my insurance, what will they have if they don't have a union job? So this was a major concern to many people throughout the state. I think when the Vermont Workers Center did their survey to see what should they focus on, because they're not a single-payer advocacy organization. They are a workers' center for lots of different issues. Fair wages, housing, workplace safety, many things. But when they surveyed their members to see what people were the most concerned about, they found that 95% of their respondents their biggest concern was health care. And so when they figured that out, that was a huge force. If you could figure out how to educate all those people who were concerned about health care about what could be better, and then have all those people contact their legislators, then you would have a major force.
Right.
So that was a turning point really for public awareness, because the Vermont Workers Center just did a bang-up job, great grassroots organizing, getting out and doing forums, and really empowering many people who previously would have thought, well, nobody's going to listen to me, I don't know what to do. They actually taught people how to email their legislators, invited them out to rallies, encouraged them to speak if they were not previously public speakers, but they had a story that would touch people and people could hear why it was so important to fix the system. They were really empowered.
Was there something unique that they did, that they got people to listen to them and to work with them and to, become a part of this whole movement?
Well, I think a lot of what had been happening before had been teaching, so that a person who was very knowledgeable would be explaining to people who were less knowledgeable. And the strategy with the Vermont Worker Center was listening. So you listen to what people were concerned about, because if you just tell them what you think they should do, and they already have their mind thinking about what they think they should do, then they may not pay much attention to you. And if you're telling them something that seems to go against everything that they have always learned, like if they all believe the free market system is the best way to control prices, then they're not going to hear you tell them why single payer should be better. But if you ask the person, what problems do you have with the way our healthcare system works right now, and they tell you, and then you chat with them about how that bad outcome was happening in the current system and what could be different. And if you help them say, well, this could be better. Oh, that's what single payer is? Oh.
Okay, so you had a mixture of what, employers, employees, and the unions actually working for the better good of the actual populace?
Employers, if they belong to businesses for social responsibility, would be likely to be among the people who might speak at a rally or something. Many business owners are very scared about it because many of them belong to the Chamber of Commerce, and the Chamber of Commerce frequently helps the local businesses buy their insurance, and the Chambers of Commerce have actually assisted in spreading some of the fear-mongering.
When you say it helps those businesses purchase their insurance, are they subsidizing them to help them to have affordable insurance, or to what extent?
So they're not subsidizing. I think that basically, if you have a company that has 50 employees, then you can negotiate a certain rate to get yours, because they want the business of those 50 employees. If you only have 2 or 3 employees, you don't have any bidding power to try to get better rates. If you belong to the chamber, and if the chamber can negotiate that our members can get this kind of plan, I think that's how, I'm not a business member, but that's my impression of how the chamber helps.
Well, what I was told is that the chamber actually does sell insurance at the state levels, which is why you see the opposition by the Chamber of Commerce to a lot of this. And yes, you're absolutely right. American Health Insurance Plans funneled a lot of money through the Chamber of Commerce against health care reform back when we were talking, going through the motions for the Affordable Care Act. So, they're not exactly an advocate in this, case.
Well, the Chambers of Commerce are not an advocate at all.
No.
The individual employers, though, if you talk with an individual employer, sometimes they don't belong to the chamber and don't read all that stuff because they can't afford to pay to be a member of the chamber.
Right.
Or because they've chosen to not be a member of the chamber because of some other reason, okay?
Yeah, and we also have to understand that we're talking about the state level and the national level chamber. Many local chambers are independent. They are not members of those groups. And the individual members of those chambers may be very favorable towards this.
Right. I think that my impression is that some of the chambers in Vermont are, rather than fighting it because they see it's not really, well, they might see this politically impossible, or they might look at it and say it doesn't make sense to fight it because it's a logical thing for our businesses too.
Right.
To be able to not have to spend money on overpriced products that profit a different company, we could keep the extra money instead of sending it to profit to somebody else to reinvest in our own company.
Right. Now, Deb Richter's group did a lot of work with the businesses, didn't she?
She did. She went around to a lot of Rotary organizations, for instance, which would have a lot of business owners in it.
Right. So that they would have had the information that they could make that determination.
That she would go and give a slideshow and answer questions and things like that.
Mm-hmm. And you have the Vermont Businesses for Social Responsibility. Was that a large group?
I don't remember how many members they have. There are some that are more active than others, and a lot of them are just little tiny businesses. And actually, some of them, I think I may have seen that Fletcher Allen was on the list, and I think there are a couple of other pretty large employers that are on it. And I don't know when they vote to endorse a particular policy like single payer. I don't know if they vote and it's just a majority thing, and the ones that don't really agree just hold back, or how that works exactly. But they have, a person that they pay to help them develop policy and to help them develop forums when they have their annual meetings. So I think it was 2000, in the fall of 2011, or maybe it was just this past fall. I think it was 2011 that they organized their annual meeting to be around healthcare and getting people from the state administration to come in and really explain what was going on, because it was so confusing, and business owners really needed to know what was going on.
Right.
Dr. Keller, at what point and how long did it take before people began to realize that their legislators were in fact listening to them?
Well, I don't know. I mean, I think that we felt that some of them were listening. I mean, some legislators have an ideology that they just won't hear what you're saying if it goes so against everything that they've always believed. They just can't hear it. And some of those, do a very good job in many other areas, and they stay in office. And some of those end up getting voted out. Somebody else goes in if they're not hearing.
Okay.
Now, the other thing, too, about Vermont that was kind of unique compared to other states, and we were talking about it here, Vermont is about the size of Northeast Ohio. Just a portion of this state. Your geography is small, your population is small, so you had a better chance of getting to more people in the state.
Right. We only have 640,000 people. I mean, that's much tinier than some whole cities. So, and they're spread out over more space.
Right.
So you can't have one legislator covering a huge number of people because they can't physically get around to see them all. So we have, several towns will have one legislator, and we'll have their House member, and then larger groups of towns will have share of senators. We have more representatives than we have senators. But anyway, we physically are able to get out and see more people with a certain, if you only can afford a few grassroots organizers, a few can actually cover our whole state. And a few wouldn't be able to do that for you.
Right. But you have a better chance of creating a sense of community statewide because of that smaller geographic area and the smaller population.
Well, that too. And then there are several other things that go into it. Our geography is a little challenged because we have a lot of boundaries, being so small and kind of oblong, so that people from New Hampshire or Massachusetts or New York, you're worried about what are we going to do for those borders for people who work on one side and live on the other, or people who decide to move here because of our health care if we're providing it for all our residents. But we don't have to worry about Canada, actually, because they have good system. They have good health care system anyway. And that closeness to Canada also means that we aren't as likely to fall for it. When people try to tell us, look at Canada, all those long waiting periods, and we say, we have pretty long waiting periods here too, and that's changed over time. We know that the waiting periods aren't as long. They were underfunded. They weren't paying nearly what we were in taxes. They weren't paying nearly as much in their taxes as what we were paying for our premiums. I'm sorry, their taxes are higher. But we were paying so much in premiums, so much money was going into our healthcare system, but we still had waiting periods too.
Right.
Dr. Keller, I know time is running short, but you said something that was really important, that you had a plan, you implemented it, and even though your state is smaller, what can you tell us here, the Workers for Single Payer System here in Ohio, what they need to do? And if you could sum it up, we'd really appreciate it.
The most important thing really is face-to-face listening and sharing. That you can't count on, one or two executive directors of one or two advocacy organizations or something. It just doesn't work. People won't hear just being preached at. They really need to be engaged in the conversations. As many people as possible have to understand it well enough that they can explain it to other people, but they have to start off by asking, what are your problems with how we manage our health care right now?
And I think sometimes you ask them, and what do you think we should do? And that opens the conversation up.
Right.
Great.
Dr. Keller, I want to thank you for having appeared on Ohio Healthcare for All. It's been absolutely a wonderful conversation. And, we definitely do want to welcome you back at another time. But we will be in touch. And to our other listeners, we do have a few messages.
Yes, we do. We've got some announcements. We'd like you to let you know that next month our guest is going to be Dr. Brad Cotton. He's an emergency room physician from Circleville, Ohio, and he has created a very unique display about our whole healthcare system, and we're having him on to talk about that. Also, SPAN Ohio is having a Walk for Health this spring. We would ask you to check our website at spanohio.org and look for the information about our Walk for Health and to join us walking for health and modeling healthy behavior. The next thing is that we are going to be presenting a play called Mercy Killers in late February and early March. Michael Milligan, who is a Broadway actor, has written this play. He's also an Ohio native, and he's bringing this play home to Ohio, and he's going to be performing for 3 weeks in Columbus, and he's also going to be performing in other parts of the state. So again, check the website at www.spanohio.org for information about the play and see when it's going to come to your community. Last thing, save the date. SPAN Ohio is having their state conference on April 27th, and we're going to make it a good one this year, so put that date on your calendar and plan to attend. So,
Okay, until then.
Yes, until then, thank you very much, Betty.
Well, thank you so much for having me, and good luck on your work out there.
Oh, well, thank you. We need it.
Good night now.
Good night.
Good night.